Bismillah ar-Rahman ar-Rahim. Hello dear. Our lecture this day is very important. It is about meningitis and encephalitis. It will be very easy lecture, inshallah. I want you to read the note I write to you, and I will discuss some point in the lecture. First of all, what is the definition of meningitis? Meningitis is an inflammation or swelling of the protective membranes covering the brain and the spinal cord. A bacterial or viral infection of the fluid surrounding the brain and the spinal cord usually cause the swelling. However, injuries, cancer, certain drugs and other types of infection also can cause meningitis. So meningitis is almost always cerebrospinal because the CSF surround the brain and the spinal cord. The infection usually also reach the ventricles by reflex through the magenta and Luschka foramens, and it usually infect the pia, arachnoid, and the spaces that they enclosed. Okay, this is meningitis. Meningitis doesn't mean an etiological diagnosis. Meningitis means just inflammation of the covering of the brain and spinal cord. It could be viral, bacterial. The most two common cause, viral, bacterial. Other causes are rare, such as injuries, cancer, certain drug, parasitic, amoebic, fungal, tuberculous. All others are rare. So it is important to know the cause, the etiological cause of meningitis, because treatment depends on the cause. As bacterial meningitis is the most serious, so we will start in discussing some point about bacterial meningitis. It is very serious and can be fatal. Death can occur as little as a few hours. Most people recover from meningitis, and this is very good news. Most of people recovered. However, permanent disability such as brain damage, hearing loss, and learning disability can result from infection. Deafness, especially in children, and especially in influenza infection or meningitis. The common causes of bacterial meningitis include the following. Usually, etiological diagnosis or the type of microorganism that infect the meninges are classified according to the age. In a newborn, usually group B streptococcus, and this is mostly coming from the mother, which she may attract the infection at pregnancy, streptococcus pneumoniae, Listeria monocytogenes, and E. coli. In the babies and children, streptococcus pneumoniae, Haemophilus influenza type B, group B streptococcus. In teens and young adults, streptococcus pneumoniae and Neisseria meningitis. In older adults, streptococcus pneumoniae, Haemophilus influenza group B streptococcus, and Listeria monocytogenes. So you notice in this classification that Listeria or listeriosis is coming in the extreme of age, that is very young and very old. So in the treatment of bacterial meningitis, we always add amoxicillin or garamycin to the regime to cover this microorganism. It's different from other microorganisms that the infection usually attracted through fecal-oral route. Risk factor which include bacterial. Not every patient, not everyone exposed to bacteria from any kind will go to meningitis. There are certain group which are affected more, such as the age, as I said, very young and very old. Group setting like camps like schools, universities, armies, is where people are crowded, certain medical conditions that decrease the immunity like diabetes, cancer, using of steroid, contact with the specimen like microbiologist, travel, and the big accumulation of people in certain places like Mecca during Hajj and during Umrah, sub-Saharan African area at time of travel, and other risk factor. Signs and symptoms in meningitis include sudden onset of fever, headache, and neck stiffness. Actually, sometimes it is sudden onset. Usually, the onset is subacute during 2-3 days. Patient complain of headache, fever, and neck stiffness. Please remember this triad. There are often other symptoms like nausea and vomiting, photophobia, that is fearing of light, the eye becoming very sensitive to light, confusion, and others. Okay, plus minus, of course, seizure, plus minus focal neurological deficit. Usually seizure in meningitis occur after passing of about 7 days, and focal neurological deficit also occur after 7 to 10 days due to vasculitis. As you know, the arteries passing through subarachnoid spaces, and these arteries may got infected and occluded, and this lead to an cortical infarction, which may explain epilepsy and focal neurological deficit. Also, in meningitis, some hormonal disturbances called SIADA may occur, and this may lead to hyponatremia, fluid overload, volume overload, and confusion. So, a confusion in patient with meningitis have many causes. It may include seizure, focal neurological deficit vasculitis, SIADA, or due to drugs. Newborn or babies may not have, or it may be difficult to notice the classic symptom listed above. Instead, babies may show slowness or inactivity, be irritable, frequent vomiting, and refusal to feed. Bulging fontanelle and abnormal reflexes can be found on examination. So, children or newborn are different from adults. Symptoms of bacterial meningitis can appear quickly or over several days. Typically, they develop within 3 to 7 days, as I told you, after exposure. Later symptoms of bacterial meningitis can be very serious, like seizure or coma. Now, diagnosis and prevention, I would talk about them later on. Treatment principle is very important in meningitis. I will not talk about the details of drugs, the doses, duration, but I remind you about the principles in treating bacterial meningitis. First of all, admit your patient to hospital. It is a medical emergency. Please don't treat your patient as outpatient. Then, when you admit the patient, you have to start empirical IV treatment without delay, because any hour of delay mean on the expense of the brain, and the patient may left with neurological deficit. You have to use bactericidal drug, no place for bacteriostatic. Your clinical guide for follow-up is the clinical feature and no CSF. So, following your patient is by noticing the fever, general vital sign of the patient, level of consciousness, etc. Choice of empirical drugs depend on the age and the clinical setting. So if you think the patient is a child, and the most microorganism can be covered by ceftriaxone, you can add garamycin or amoxicillin to cover listeria. You may add steroid for short period to prevent or decrease the incidence of deafness. Give the antibiotic in meningitic dose, please. The doses in meningitis is very high. We need very high dose of a drug to cross the blood-brain barrier, no simple dose. For example, in clavuran, we may give cefotaxime or ceftriaxone. We may give up to 2 grams each hour. Now, what about viral meningitis? Viral meningitis is the most common type of meningitis. It is often less severe than bacterial meningitis, and most people get better on their own, that is without treatment. But babies and older people may need admission and much more care, because they are more likely to have severe illnesses from viral meningitis. Causes of viral meningitis is the usual viruses present in the environment, like non-polio enteroviruses, which is the commonest cause, called Coxsackie viruses, Mumbs Herpes, Epstein-Barr viruses, measles, influenza virus, Arbo viruses, and the Listeria lymphocytic chorio meningitis virus. People at risk are the same. As you know, these viruses are transmitted by maybe transmitted by a breathing droplet or by orofecal. So general hygiene, cleaning of the hand, keeping a social distance may you can avoid these viruses. Diagnosis and treatment is the same for all meningitis, most of the meningitis, with a few exceptions, of course, I will talk about later on. Prevention and vaccine, you know, some of these viruses have vaccine, like measles, like herpes, like polio, mumps. Certain viruses are till now with no vaccines. The third groups of meningitis is fungal meningitis. Some causes of fungal meningitis include Cryptococcus, Histoplasma, Blastomyces, and Candida. It is usually present in the environment. Most of these microorganisms are present in the soil, in the decayed woods, in the contaminated soil from birds. So person got infection with fungal meningitis usually after contaminated by droppings of birds, or sometimes, as in Candida, it may spread to the body from skin or mucous membrane after decreasing of immunity. So this spore may got or reach the lungs, and from the lungs it may reach the brain or spinal cord. And the important note about fungal meningitis is that it usually affects immune-compromised patients, like patients with HIV, patients receiving steroid for long times, patients with cancer, chemotherapy, patients with taking anti-ANF drugs, biological drugs like rituximabs or others drugs used in rheumatoid arthritis. Parasitic meningitis also is very rare. Some parasite can cause a rare form of meningitis called eosinophilic meningitis or eosinophilic meningoencephalitis. People get infected primarily by eating infected animals or contaminated foods, like eating bats or eating some raw animals, not goodly, not cooked in a proper way. These may include canto, nenes, brocyanus, and spinigerm. Primarily, amoebic meningoencephalitis is a rare brain infection that's fatal and caused by Naegleria fowleri. This microorganism live in hot water, example swimming pool, hot spring, etc. It does not live in salt water. It enters the nose and reach the brain from the nose. So in parasitic infection, please remember it causes eosinophilic meningitis. That is an inflammatory process, and the presentation is the same as meningitis, and it reach the brain spinal cord by eating contaminated foods, infected animal. In amoebic, usually it coming from hot. When one put hot water in his nose, like in certain habits by some people, it may reach the brain also and cause the infection. These are the infectious causes of meningitis. Also, you have a non-infectious meningitis like cancer, systemic lupus, erythematosus, drugs, head injury, and neurosurgery. So this is an idea, short idea about the different causes of meningitis. Bacterial and viral remain the top two causes of meningitis all over the world. Now, how we reach a diagnosis in those patients? First step is to do general examination of the patient, neurological examination, especially concentrating on papilledema and any neurological deficit, level of consciousness, and the vital sign. We can collect swabs from the nose, the throat. We can do complete blood culture and complete blood count and cultures, specimen from the stool, specimen from the urine, looking for everything. But the final diagnosis actually depends on collecting cerebrospinal fluid from the patient. Normally, CSF had an opening pressure of 5 to 18 centimeter H2O, about 60 to 150 millimeter. Glucose 3.3 to 4.4 millimole, that is more than 2/3 of blood glucose, and a protein of 0.15 to 0.45 gram per liter, and the white PC must be less than 5 in a cubic millimeter. Now, what happen in different type of meningitis? That's bacterial, viral, tuberculous. The appearance is cloudy in bacterial. In viral, it is clear to cloudy, and tuberculous, it's fibrin web, especially after letting the tube in a standing position for an hour. Glucose is low in tuberculous, and bacteria is usually less than half of that plasma, while it is normal in viral. Protein is high, more than 1 gram per liter in bacterial and tuberculous, and it's normal to slight raise in viral infections such as mumps. The white BC is also elevated in both bacterial, viral, and tuberculous, but in tuberculous and viral, it is predominantly lymphocytic, while it is polymorph in bacterial. What are the condition? What are the causes of elevated lymphocyte? This is very important. I ask you to memorize them correctly. Viral meningitis and encephalitis, TB meningitis, partially treated meningitis, SLE, Behçet disease, leukemia and lymphoma, and Lyme disease. All those cause elevation of lymphocyte. The following conditions are associated with increased protein. These are bacterial, fungal, and tuberculous meningitis, viral encephalitis, and Guillain-Barré syndrome, spinal block, which is called the Freund syndrome. Freund syndrome describes an increase in CSF protein below a spinal canal blockage due to tumor, disc, or infection. This paper is very important because of increased lymphocyte and cause of increased protein. Zeller stain is only 20% sensitive in the detection of tuberculous meningitis, and therefore PCR sometimes used. Sensitivity is about 70% of cases. Mumps is unusual in being associated with a low glucose level in proportion of cases. A low glucose may also be seen in herpes encephalitis. So in viruses, usually glucose is normal with a part of mumps and herpes. Now we have a very important topic, the last topic, what is called post-lumbar headache. That headache which follow lumbar puncture occur in approximately 1/3 of patients. The pathophysiology of it is unclear, but may relate to leak of CSF following dural puncture. It is more common in female with a low body mass index. Typical features include develop within 24 to 48 hours following LP, but it may occur up to 1 week later. May last several days, worsen with upright position and improve with recumbent position. What are the factors which may contribute to increased headache? These include increased size needle or needle size, direction of bevel, not replacing the stylet after aspiration of CSF, increased number of LB attempts. Those factors are increasing post-lumbar headache, so please be aware of them. The other factor which do not contribute to headache, they talk about previously, include increased volume, CSF removed, bed rest following procedure, increased fluid intake following procedure, opening pressure of CSF and position of the patient. All these are not effective. Management of post-lumbar headache includes supportive initially, analgesia and rest. If pain continue more than 72 hours, then a specific treatment is indicated to prevent subdural hematoma. Treatment options include blood patch, epidural, saline, and caffaine IV. This is what I want to tell you in meningitis. It is a big topic. There is a lot of talk, but I actually told you the most important things in bacterial meningitis. Read it again and again, and be free to ask me anything about meningitis. Now we are talking short about encephalitis. Encephalitis, as I said, difference of meningitis from encephalitis is sometimes very difficult. But generally, there is an herpes simplex encephalitis. In addition to fever, headache, there is usually decrease in the level of consciousness. You may find focal neurological deficit. Seizure is frequent. The onset is the same. Meningeal sign may be absent in encephalitis, and it is usually more common in meningitis. Also, encephalitis may present in different way, actually, according to the area involved. If it is in cerebellar, like post-chickenpox, the patient may present with ataxia. If it is in the brainstem, the patient may present with long tract signs or decrease in the level of consciousness. If it is in the temporal lobe, like herpes simplex, encephalitis, it may present with psychiatric symptoms. So it will depend on the area of the brain it is involved. The difference here is the parenchyma of the brain is affected, while in meningitis only the coverings of the brain is infected. Sometimes both occur together and called meningoencephalitis. Encephalitis purely, I will talk about the most important of these, which is called herpes simplex encephalitis. The virus characteristically affect the temporal lobe. Features include fever, headache, and vomiting. As you see, these are similar to meningitis, but you have a different unique to herpes, which is psychiatric symptom, change personality, odd behavior, becoming aggressive over trivial things, confusion, and seizure. Focal feature example, aphasia may occur also due to affection of Wernicke area. Peripheral lesion like cold sore have no relation to presence of herpes simplex. Pathophysiology, herpes simplex virus type 1 responsible for 95% of cases in adult, and typically it affects the temporal and inferior frontal lobe. Investigation for herpes simplex encephalitis includes CSF, which may show lymphocytosis, elevated protein. We may ask also for PCR for herpes simplex virus, which is the quickest method. CT and MRI is very beneficial. MRI is better. Medial temporal and inferior frontal changes like petechial hemorrhage, low attenuation areas with surrounding edema. But remember that CT MRI may be normal in 1/3 of patients. EEG may show lateralized periodic discharge at 2 Hz, but also again it is not diagnostic. Treatment option or treatment include acyclovir 10 to 15 mg per kg or 30 mg per day every 8 hours for 10 to 14 days. The prognosis dependent on whether acyclovir commence early. If treatment is started promptly, the mortality is 10 to 20% only. Left untreated, the mortality may approach 80%. So please, if you suspect a patient with encephalitis, in addition to the classic triad, fever, headache, and neck stiffness, plus minus neck stiffness plus seizure plus focal neurological deficit, decrease in the level of consciousness, start acyclovir as quick as you can because it may save the patient. The neuro complication of HIV is very common in the questions, both for undergraduate and postgraduate. Please read about them. They include three or four generalized complications, which are encephalitis, cryptococcus meningitis, progressive multifocal leukoencephalopathy, and age dementia complex. The focal complications include toxoplasmosis on the top, lymphoma, and TB. This is a case problem at the end of the session. Please solve it after reading the lecture carefully and send me the answer, please, within 24 hours. I hope your cooperation. Please don't sleep. Please don't sleep too much. I don't receive from you any interactions. Probably I will stop giving this lecture if you continue on this detachment from the lecture, and will let you reading your books only. This is the last red card. Please be cooperative, interact with the lecture, and send the question if you want. Be free to ask. Thank you very much.